Thank you very much, Professor Nanda. That was an excellent, very exciting presentation. We wished we will go on for some other time, but I think I'm going to, Dr. Nanda has ordered me to actually summarize my talk within 5 minutes, which I will do actually. Dr. Narula already has covered some of my slides, so basically I'll be very, very brief because it's lunchtime. But thank you very much, Dr. Nanda and Dr. Chopra and the organizers for giving us the opportunity to make a brief presentation here. It's an intravascular ultrasound examination. Is an examination which actually we should all be doing, but unfortunately we don't do enough of intravascular ultrasound IVUS examination because of time constraint and meager facilities available not only in the United States but all over the world. But the common test we do is the so-called angiogram, which is a lumenogram, which actually gives you very minimal information about the plaque morphology in the coronary artery disease. It doesn't tell you everything. And also one more thing, just want to tell you a few points I just want to bring home. Acute coronary syndrome, so-called unstable angina, myocardial infarction, are nothing but a manifestation of a systemic process. It's not just coronary disease, a systemic process, the inflammation, which actually targets the coronary arteries. Therefore, it's a dynamic, continuous process. And the tests we do with a stress test, CTA, IVUS examination, coronary angiogram, whatever we do is a snapshot. It's not a, it's not a continuous process. So in the future, in 50 years from now, Dr. Narula went back to 3,000 years, 50 years from now, I think there will be nano IVUS, nanobots, police, the cops parading in the vascular vessel walls, and they will be signaling us. That will be a different era that we're looking forward to. So anyway, severe symptomatic ischemia in unstable angina are due to, as Dr. Narula showed, due to thrombotic occlusion of the friable, lipid-rich coronary lesion with thin fibrous cap. So these patients, after heart attack, they're at a higher risk of recurrent coronary events in the first year itself. So we have to be careful to make sure that there are not other lesions, so-called remote lesions, which will cause the acute coronary event. So as we talked about coronary angiography being just lumenogram, it doesn't tell you everything. Therefore, we should be doing intravascular ultrasound examination, which is almost has become a standard, to see any remote lesions, hidden plaque burden, assess the extent of the plaque, the quality, the texture of it. That way, we can take care of the other lesions too. So IVUS provides, as you know, intravascular ultrasound examination provides tomographic imaging of the coronary atherosclerosis. It tells you the plaque area, distribution, lesion length, how long it is. Coronary remodeling, the Glagau adaptive remodeling will become evident in IVUS examination. Basically, IVUS will narrow our gaps in knowledge regarding discrepancies between the atherosclerosis of the vessel and actual visualization on the angiogram. So Dr. Narula already has pointed out in his nice, elegant slides, the tissue characterization IVUS examination can be performed. But you can characterize fibrous tissue, fibrofatty tissue, necrotic area, dense calcium, with either color coding of the radio frequency signals showing. So then we can identify the high-risk lesions. So in this cartoon, you see, just like Dr. Narula's slide, you see the thin wall caps here, it ruptured and caused a thrombotic lesion causing acute coronary event. And again, this is Dr. Narula's slide itself from the journal there. We already went over that. So we just want to make sure I just make a point here. The acute hemi is not only due to one lesion, but also at the same time there are other lesions because the inflammation is diffuse. The remote lesions, they have to be characterized and see whether they need intervention also. Dr. Sharma was pointing out that yesterday. So I will identify those lesions. Is a culprit lesion. Sometimes younger people have a heart attack with a lot of clot, but the residual lesion is only small. So in that case, we have to make a decision whether you're going to go ahead and put a stent or the self-degrading stents, bioabsorbable ones, or leave them alone, just put them on optimal medical therapy. That could be helped by IVUS examination. IVUS also characterizes the size of the lesion, the so-called minimal luminal area, which is in the cutoff lesion, cutoff length is the area is 3.0 square millimeters, and that usually predicts the to some extent, coronary events. When it ruptures, on top of the smaller lumen, you have a clot that leads to coronary event. So also, we talked about more accurate identification of the size of the lesion and also the texture. This will lead us to appropriate management of the lesion. So Fujii et al. Pointed out that not only the lesion rupture that leads to acute event, but also the size of the lesion. In other words, small plaques, even though they can be highly inflammatory and they can be highly thrombotic, because of the adaptive remodeling, they don't necessarily cause MIs. So this is a combination of severe lesion with a plaque rupture. This is a combination of these two processes which leads to MI or unstable angina. So as you can see, the higher the lesion, the more necrotic area, thin wall cap, that is more likely to cause heart attack. So basically, the acute coronary event is a balanced imbalance in demand-supply ratio because of severe lesion and the clot formation on top of the severe lesion that leads to the acute event. Normally, while we are sitting here in this hall, I'm sure we are having small lesion ruptures and which will be cleared by TPA, our own TPA, and then it heals up. Then we don't know it is happening, but it's happening. So then it's a recurring event when it culminates in an event when it's a severe lesion and big rupture and also big thrombus. As you can see, this again, Garcia and Dr. Narula is a co-author on this. Quickly, the cartoon says in the stable lesions here, the bottom of the slide here, the stable thick cap and very stable, even though it's a mild degree, a severe degree lesion, even this one causes stable angina. It doesn't necessarily cause event. As you go to the thin wall on the top, you see a thin cap, and that will lead to rupture. But a small lesion doesn't cause heart attack, but medium size and the severe stenosis, on top of that, it causes heart attack. So going back forward, the other the modality of imaging is, as you know, optical coherence tomography, so-called OCT, which will give you, next slide, basically more surface details, whether the cap is thin or thick, it will give you the details, and resolution is better. But overall, the IVUS examination is far better, and we have a lot of data on that, and this provides you more data. So IVUS is a standard. So virtual histology, we talked about the green, which is not very hot, but red being very hot. That's the product of IVUS examination. You can go by virtual histology, but it's not entirely accurate, but it will help you identify the high-risk lesions and manage them appropriately. For example here, so you can see the green, the stable lesion, and the hot areas are very hot inflammatory lesions. And also the IVUS examination, you can see it provides you length of the lesion. So you can appropriately size the not only length, but also diameter of the stent. So the stent misalignment can cause recurrent coronary events. So IVUS examination will provide you the exact morphology so that you can put an appropriate stent alignment. For example, you can see that stent is covering the entire lesion. If you leave some of the lesions, that might cause recurrent events. So IVUS will help you that. In conclusion, IVUS examination during acute coronary event will characterize not only the quantity, the degree of lesion, but also its characterization, the tissue texture, so that you can appropriately manage the patient to prevent future coronary events. But thank you very much for your attention.
Thank you very much, Dr. Reddy. I think it's a great talk. Wish we had some better resolution, imaging resolution with IVUS. I think wish we really had more time for this very important session, and with the luminaries sitting here, it's a really very important session. I just wish we had more time.